Good afternoon, everybody. We want to thank you for taking the time to be with us today. Thank you for joining us during this webinar. It's Practical Strategies for Social Risk Screening During COVID-19. And we just wanted to take this time to set the tone a little bit. So hold on one second. I'm trying to advance the slides.
Oh yeah, if you click on the slide, Eureka, and do the right hand.
Oh, there it is.
There you go. And if not, I can do it for you.
Okay, if you can, because it's not doing for me. Sorry about the technical glitch. So we wanted to let you all know that today's webinar will be recorded. Afterwards, we'll be sending the resources such as the slides as well as the recording of the webinar to all of you. And we're going to go through a little bit of housekeeping in terms of how to use Zoom so that we can use the features to engage with each other. And then we want to acknowledge the new realities that we're in. So we know that everyone's working from home or working remotely. So we've got kids, furry friends, sometimes unstable internet, renovations, you name it, we have it. So just be, we're going to be mindful of that. And we ask everyone to, keep yourselves on mute if anything. So we might, some of us may be new to Zoom, some of us may not be, but I just wanted to go really quickly through the features within Zoom. You will have the ability to, see how you can add questions within the Q&A portion, you can raise your hand, you can chat within the platform. So these are features meant to allow us to engage with you and you to engage with us as well. So we want to encourage you to use it. We will have polls throughout the webinar so that we can get your feedback, get your insights as well. So we welcome you to use it. Any questions you have, there's a team of us behind the scenes that will be monitoring the webinar in terms of the chat and the Q&A. So please feel free to engage with us during this webinar. So here's the first quick poll. And we wanted to get a sense of who's in the room. So this question, we want to see what kind of organization you are currently working at. We want to get a sense of who's here. We had a lot of different registrants sign up for the webinar, and we want to see who's in the room right now. We can't see you all, so we'd like to know who's in the room. We'll give you guys a couple more seconds. Wonderful. We have some folks that are putting in the chat as well, so thank you. We'll give you folks another couple more seconds. Okay, so there's a comment that some are not seeing the poll. Should be front and center. If it isn't, take a look down at the bottom of the screen. You should see some features there that it should be popping up. So, okay, so we have a lot of health centers that are in the room. Sorry if you can't participate in the poll, feel free to add it in the chat box. If you're from a health center or PCA or from an NTAP, just feel free to share it in the chat. And apologies if it's not working for you. I know there's been a recent update, so people are having difficulty accessing Zoom. All right. So thank you. All right, so we're gonna go ahead and move on. So right now, I just wanted to go a little bit into what today's session will entail. So my name is Eureka de la Cruz. I'm the Social Determinants of Health Manager at NAC. And I'll be providing a little bit of an overview of using the social risk screener, using patient-centered approaches and principles. And then we've got 3 phenomenal speakers today with us, and I'll share a little bit from their bios. I wanted to share that this is the project team at NAC and AppShow. We've got, a wonderful assortment of professionals and experts that have been leading the work around PRAPARE. And we also have a new partner, a new colleague that's joined the team. She just joined us last week, Nalani Tarrant. So we have to update this photo, but wanted to share this. We wanted to share this for you all to see who's on the team. All right, so today's speakers. So we have a wonderful, like I mentioned earlier, we have a wonderful panel of speakers today. First, we have Maria Reyes. She's the manager of community health education at La Clínica de la Raza. She has been primarily responsible for implementing, overseeing, and supervising community health education initiatives and outreach efforts that involve youth peer health educators, promotores, and community health educators. These efforts have tackled early cancer detection, youth development, senior services, healthy and active living, oral health, outreach and enrollment into health coverage, patient navigation of the healthcare system, and political literacy and advocacy. She has overseen the piloting and analysis of La Clínica's utilization of PRAPARE, and she's also in charge of planning, developing, and coordinating and supervising health education's program within Contra Costa and Solano counties and supervising La Clínica's programs in Alameda County. So thank you, Maria, for joining us today. The next speaker that we have, I know she'll be joining us shortly, is Rosa Maria Martinez. She holds a master's degree in business administration and a bachelor's degree in dietetics. She has served in different capacities in her tenure at 16th Street Community Health Centers. Prior to her current role as Vice President of Community Health Initiatives, she served as Women, Infants, and Children Director. In her current role, she provides strategic guidance, direction, and ongoing support to all programs within CHI. She currently serves on the Board of Directors for Harbor District and is on the Board of Visitors for UW Extension. Rosa Maria is fluent in Spanish and she grew up in the community currently served by 16th Street Health Center. And finally, but certainly not least, we have Beth Thorson. She completed graduate study in clinical social work at the School of Social Service Administration, University of Chicago. She holds a master's degree from the Center for Bioethics and the Medical Humanities, Medical College of Wisconsin. She has worked in acute and clinical settings with vulnerable populations, including refugees, the chronically ill, and the uninsured. Currently, she is Director for Social Work Services for the Free and Community Clinic Collaborative, a collaborative of 23 clinics in southeastern Wisconsin. She leads the Community Health Resource Center at Bread of Healing Free Clinic in Milwaukee, which is sponsored by the Milwaukee Healthcare Partnership. Bread of Health Clinic was recognized as UWM Fieldwork Agency of the Year in 2018 for excellence in social work training. Beth was awarded the President's Community Engagement Award from the Medical College of Wisconsin in May 2019. She has been a member of the Froedtert Hospital Ethics Committee since 2002. So thank you to our speakers for joining us, just a bit of them and their amazing experience that they bring today. We wanted to acknowledge our support for today's webinar. We've received funding from the Robert Wood Johnson Foundation, and we wanted to just acknowledge their efforts to support us and really helping to build the capacity of health centers in terms of cross-sector alignment and partnerships so we can advance health equity within our communities. So along those lines, we wanted to provide a little bit of background in terms of, with the support of Robert Wood Johnson Foundation, one of the things that they've really been promoting is cross-sector alignment within the fields of healthcare, public health, and social services. And so this is a theory of change. I'm going to just go very briefly through it. But these are just some of the elements or the enablers within the organizations as well as within the community that help promote some sort of progress towards improving health and well-being within communities, and especially with communities that are at most risk of health inequities. So within the theory of change, they looked at 4 different domains: shared vision, so that's purpose; data, so how do we create a shared data and measurement system; financing, in terms of how do we create sustainability within our systems to create healthy communities; and then finally governance, how do we create leadership and appropriate roles and relationships within these 3 sectors. And at the bottom, supporting all of this is really, it's grounded in strong community role and engagement. So what's unique about the health center movement and why we're really excited to be partnering with Robert Wood Johnson Foundation is that health centers have been leading the way in terms of how do we collaborate and engage with our community partners. So just wanted to provide a little bit of that background. And just also with the webinar series that we kicked off back on October 8th, we wanted to provide a series of different webinars to help the field in terms of understanding how do we best support you. So we had a survey back in May, as well as a community conversations. In May and June, we had these different engagement strategies with health centers and PRAPARE users in particular. And we found that there was a real need in terms of how do we collect social determinants of health data during COVID. You know, COVID has really changed the game and really altered our workspaces and our workflows. So we wanted to get a sense as to what's happening in the field currently, and then how do we help health centers with their cross-sector partners move along within our current realities. So this is how we came up with this webinar series. Like I said earlier, the first webinar was a couple weeks ago, so we do have the link for the slides as well as the webinar recording. There is a passcode, so if you do access the webinar, you have to use the passcode in order to access it. And then today, this is our webinar, the second one in the series. And then the third one will be next week. And this webinar will be looking in particular to emerging strategies to address SDOH through community referrals and cross-sector partnerships. So we're really going to talk about how do we engage community partners across different sectors. And we're going to have, again, a great panel of 3 different speakers that will talk about their experiences. So I do want to launch another poll real quickly. So before we move on, I just want to get a sense from the room in terms of webinar topics that you guys would want to hear from us. So we identified some topics through the feedback, through different avenues. And since we're planning more webinars in the future, we wanted to get a sense from all of you what would be some priorities or some webinars that we should focus on. Okay. So I'm going to go on with the slides. And so I want to talk a little bit about the importance of patient-centered approaches. So this section, this portion I'm going to talk about is really just a very bite-sized overview in terms of the art of asking these questions. So the PRAPARE tool is the structure, it's the science, if you will. We know in medicine there's an art and a science to everything. So really today's webinar, we're really focusing more on the art of it, understanding that our staff, it's really an important strategy in terms of looking at what are some different approaches that we can utilize so that when we ask these questions, we essentially build relationships with our patients. We have, there are different approaches within our toolkit, so you can find a lot of these informations and approaches within chapters 2 and chapter 5 of the PRAPARE implementation and action toolkit. But really wanted to have you to just share with all of you in terms of how to utilize empathic inquiry, how do we meet our patients where they're at, and really understand how do we build relationship using these questions. We want to shift the mindset from collecting data to really getting to know our patients in a very intimate and personal level. And really want to understand and acknowledge the fact that asking these questions is very difficult. It's something that our patients may not be used to. It's something that our staff may have difficulty asking these questions. You know, these questions may remind them of their own past, of their own current situation even. So we have to keep in mind that asking these questions it's very sensitive. So we want to be able to provide our staff with as much resources as possible so that they can ask these questions in a way that's very patient-centric, but also takes care of them as well. I really want to emphasize again that using PRAPARE is, you know, there's many tools out there, but what the beauty of PRAPARE is that we have different resources. We have a toolkit with a lot of different strategies and approaches that you guys can use in terms of asking these questions, and really just how do we enhance the patient experience, their health outcomes, but also take care of our staff so that we know that we're not burning them out, because there's a lot going on nowadays. The next slide, please. So understanding that we're in the current realities of COVID and we can't see our patients face to face, that's a challenge that it's been really difficult for a lot of us. So we wanted to just highlight just a couple strategies that we've heard from different folks in the field in terms of asking these questions, using patient-centered questionnaires or the patient portal. If depending if your EMR platform has the patient portal, definitely utilize that to ask these questions if possible. We've heard of health centers being able to send an email to their patients to ask these questions before a visit. And then it has a link to the screening tool, and they're able to then get the information and hopefully review before or during the patient visit. Some health centers are able to use tablets or kiosks for patients to answer these questions. And then finally, we have a paper form, understanding that for some people, it's easier just to have the paper form completed. We know paper form might be needed, but we want to encourage folks to move away from that, only because it's a lot of work for our staff, and it leads to double entry sometimes as well. So these are just some strategies. Again, this is the science part, if you will, of asking these questions to our patients. But these strategies really help meet our patients where they're at. And understanding that sometimes these questions may be difficult, allowing the patients to answer these questions, on their own individually can allow for more transparent conversations within the patient visit. So then these are two examples. So one of the other things that we've heard from our PRAPARE pioneers and our champions is that it's really important to talk about the importance of why we're using PRAPARE, why are we asking these questions, and it's important to have these messages defined and outlined for patients, but also for staff. So these examples are in the toolkit again, so just want to point you all to the toolkit. There's a sample of an email here from Lone Star. This is a very brief email that they came up with, and there's a link to the survey there. And then the other example on the right-hand side is a sample script, which is great because I think it allows, when we equip our staff with the script or the language that we should use when presenting or introducing PRAPARE, this helps alleviate some of the pressure, some of the stress with having to explain, well, what is PRAPARE? So these are just two examples. I definitely encourage all of you to take a look at the examples that are in the implementation toolkit, but more so, pilot it. Look at the language, look at the words that are being used, adjust it for your population, for your patients, test it out, and get feedback from your patients. All health centers have, we have board members that are representative of the community, staff. So get feedback from everyone as much as possible to make sure that this makes sense for your patients and your staff as well. So again, this was bite-sized, by no means the full course, if you will. These are tapas, if you will. But right now I want to hand it over to our presenters. Again, wonderful experience, wonderful efforts that they've been able to lead in their health centers, and we want to give them more time to share their journey. So I will pass it over to Maria Reyes from La Clínica de la Raza.
Hi, good afternoon, everyone. Can you hear me okay?
You're good, Maria. Yep.
Great. So thanks again for the opportunity to participate and to share our experience implementing PRAPARE at La Clínica. So La Clínica is a community-based organization, a QHC, that has been in existence for 49 years. We'll be turning 50 next year. And since its inception, it has expanded to 3 counties, Alameda, Contra Costa, and Solano. And in 2019, 91,000 patients were served, 367 visits provided, and to date, 1,200 people are employed by La Clínica. Our mission is to improve the quality of life for the diverse communities we serve by providing culturally appropriate, high quality, and accessible healthcare for all. So next slide, a little bit about our services. 64% of our patient population is Latinx, and then the rest of the population includes Asian, Pacific Islander, African American, and other groups. Our payer mix is 65% Medi-Cal, 22% uninsured, and the others include Medicare and other private insurances. And let's see, next slide. In our services, we provide a variety of services from medical, dental, optometry, clinical health education, and behavioral health, and community health education as well. So I oversee the implementation of the community health education services at La Clínica. This is a picture of our Contra Costa Solano community health education team. In total, we have approximately 45 staff across the 3 counties. And our goal is to promote and improve the health of our communities through prevention, access, community engagement, and empowerment. Next slide. So since 2017, when La Clínica first received funding from NAC, we began to pilot the PRAPARE tool. And at the time, our goal was to collect data for 400 patients utilizing the tool. And since then, we have expanded it. At the time, our main focus was implementing it with our enrollment assistance staff. Since then, it has expanded. We continue to have our community health educators who are also certified enrollment counselors implement it. As they do the enrollment, they utilize PRAPARE to assess other needs. Similarly, for our mental health stigma prevention program called Opening Minds, Closing Stigmas, our health educators do classes in the community. And in one of the sessions, they dedicate a session to talk about resources, and they also utilize PRAPARE to assess the needs of the particular group to then tailor resources available in the community. More recently, with COVID and the shelter in place, we utilize calls. We run lists of our Contra Costa Cares patients who are beneficiaries of a county program that provides services for undocumented adults who are not eligible for Medi-Cal. And we use those lists to call them and assess their needs, particularly around COVID, around the shelter in place. Similarly, more recently, we utilize lists for self-pay patients to also screen them for eligibility for coverage and also assess social determinants of health. The next two programs, the T3 Plus Navigator and the Transitions Clinic, are programs that incorporate PRAPARE through a patient navigation model. So T3 Plus is a navigator. It consists of a navigator that is located at the hospital setting, working with patients discharged from inpatient care. PRAPARE is utilized at bedside as the patient is getting ready to leave the hospital to be able to make sure that they are linked to a primary care provider or transportation for follow-up care or food or other resources they can benefit from. The Transitions Clinic is based out of North Vallejo site in Solano County, and this is following the model of the Transitions Clinic network. The focus is to reach out to formerly incarcerated and link them to primary care at La Clínica, particularly between from the point of discharge and catch them within 6 months from release or incarceration. In the next slide, you will see our team. And on the left side, you will see Madonna Garcia-Crowley. She's our patient navigator. And Dr. Ann Finkelstein on the right-hand side. And they work with a care team at La Clínica that is responsible for providing the resources and the services. Madonna is our navigator who utilizes PRAPARE at the point of intake. And what's very unique about this particular program is that and a reason for its success is that it requires building trust from the beginning, early on. And so Madonna can have a conversation around PRAPARE over a cup of coffee, over a microwave meal, as the patient comes in for the very first time. Some of their data includes that within 6 months of service, 33% of the patients reported improvement in health, 40% were successfully linked to healthcare, and 50%, I believe, were actually linked to employment, part-time or full-time. It's cut off a little bit. Yeah, 50%. And something also really exciting that I just learned about yesterday is that the program was recognized as a Medi-Cal Managed Care Quality Award runner-up. So we are very excited about that. Next slide. Some of the learnings for us is that PRAPARE has been a tool to be able to document the complexities of our patient population. It also helped us reinforce and build a case to our funders about the need to implement programs or to advocate for policy change. So, for example, in Contra Costa, a particular city, was working on rent control. So La Clínica was able to write a letter of support utilizing our PRAPARE data to talk about within the patient population in that city, how many of them were homeless or had fear about losing their housing. And so we were able to utilize that data to build our case and provide the letter of support. Similarly, it's a good tool to help us determine and make decisions around program design and scope of work. And within our department, community health education, we have really made a decision that we would like to implement PRAPARE as much as possible. Like I said, there are some programs that seem to be more adaptable or that is easier to implement PRAPARE, particularly those that are doing patient navigation, but we also are learning and experimenting ways in which we can implement PRAPARE in other programs, including those that are doing work out in the community. So not only with our patients, but also with the general public. Next slide. So today, La Clínica continues to gather data. We have collected information for about 2,500 patients, and the findings are very similar, particularly with COVID. There has been an increase on the needs for housing, for food, an increase on challenges related to mental health, stress, and anxiety. And in some parts of our county also experience challenges with transportation. Next slide. Some of the staff training that have been implemented include kickoff meetings at the start of every project to make sure that the staff feel confident and comfortable and understand the plan for program implementation. We've done data collection and data entry training, role play on how to hold a casual conversation and incorporate the questions in a casual form as much as possible. We've also done training about how to utilize the 211 database, how to enter data. We recently went through a change from NextGen to EPIC, and so teaching our staff how to do those data entry, and then more recently, also how to input data around the ICD-10 codes. Other trainings, particularly for staff, collecting information at boundaries when working with patients, compassion fatigue, and motivational interviewing. Next slide. The future for La Clínica around PRAPARE is like I said, we'll continue to implement it in as many of our programs that we can. We are looking to implement a collaboration with 211 so that, one of the limitations we have is we know we refer people to resources, but we're not always able to close the loop and understand if the person accesses those services. So we're looking to partner up with 211 so that they can help us close that loop and provide us back the information as to whether the patient or community member accesses those resources. We also are in the process of implementing PRAPARE in a veteran peer navigation project. So we're going to be offering services to veterans, and that's very exciting. So we'll also be utilizing PRAPARE to screen for services, and we're also in the process of working on getting reports through EPIC and the ICD-10 codes. So the data is now in. Now we're learning how to run those reports using the new EPIC portal. So yeah, I think that concludes my presentation. Thanks for your, again, thank you very much for the invitation. Very much appreciated.
Thank you, Maria. So we're going to transition smoothly into the next panelist. This is, again, Rosa Maria Martinez from 16th Street Community Health Centers based out of Milwaukee, Wisconsin. So we had a little bit of tech issues, but we got Rosa Maria on. So glad to introduce her, and we'll kind of take it over from here. Hi, Rosa Maria. All right. We'll just have to unmute your phone and then we'll be good to go. There you go.
Okay. Can you hear me now?
You're good.
Okay, great. Well, thank you very much. Nothing like a little bit technical stress right before a presentation. I think my cheeks are a little red, so also give me a little blush. Good afternoon, everybody. So 16th Street Community Health Centers, we've been around for 50 years. We celebrated our 50-year anniversary last year. So very excited. We're a federally qualified health center in Milwaukee's South Side. So for those of you who are not familiar with Milwaukee, the Milwaukee South Side is primarily Latino. Unfortunately, we've been a segregated city, so South Side has been primarily Latino, although we have been changing. The community has been changing a bit, so happily. We are aimed similar to what Maria was saying about La Clinica. I feel like all of us, La Clinica and Bread of Healing, are family, because in our DNA is really to help reduce those barriers for our families and for those who come see us. So that is a key to who we are in our history, and as Maria also mentioned, the trust that we've built. And right now we have about 43,000 patients, which is a huge increase from what we had previously. Our organization started really in a jewelry store, so it was very, very small 50 years ago. So we are glad to have grown to who we are today. Next slide, please. We do have six locations at our. We also work in schools and have a large women, infants, and children's program. And a little bit about our demographics of our patients. As I mentioned, we're primarily Latino. Majority of our patients prefer to be served in a language other than English. We have about half of them are under 18, so a pretty young population. And about 80% are underinsured or uninsured completely. So, and we have about 76% of our patients who live below the federal poverty line. Next slide, please. I do also want to note that it is very important for us. Quality is key. So we build the trust with our community because I think they know that we work hard to listen to them and to offer the best that we can. And we are so happy to say that we have received the HRSA Health Center Gold Quality Leader, which is really just given to the top 10% of all HRSA supported health centers. So we are very proud of that. And there are many other awards that came along with that, but I thought that I wanted to at least share that one with you. So that's, next slide, please. It's a little bit about our clinics. I wanted to share a little bit about the screening, and I will do so primarily in this one slide, just to kind of give you an overall. So a little bit different from what La Clinica described. We do, our screening has been done primarily by our volunteers, and I'll describe a little bit more. We received a WPP grant, which is through our state university. It's a 5-year grant, and we're in our second year. Our first year was a lot of structure building, and we aimed to really grow our department and grow our services, knowing that we have limited staff. So at the time of when we started working on all of this years back, we know that we were serving only about 2% of our patient population. And that is, granted, at that point we were understaffed, and so at one point, so just so you recognize that. But as we screen, we realized about 30% of our patient population indicate a need. So you go from that 2% to the 30%, that's a huge jump. So really what we wanted to do is how do we leverage that? We don't have, like many of your centers, we don't have oodles of dollars to just hire. So what we tried to do was leverage the staff that we had and build on our partnerships. And so what you see here is what we were aiming to do in having a tiered leveled service. So we realized that our social workers, some who are master level social workers, we wanted them to work to the highest, to their potential and their license. And we know that we also wanted to have somebody to walk through those questionnaires with patients. As was mentioned a little earlier, giving them the paper documentations, there's a lot of concerns with that. We tried that with piloting that, and people just didn't seem to be as interested in completing that or had questions, and so we didn't get a lot of response. So for that reason, we wanted to build in someone who could go through that document with them and ask just to give a general, just go through the questions. If they wanted help, if they didn't, people are we're more than happy to let them complete that and give that back to us. But you see that blue arrow, that is really aimed at those volunteers. It's really just the universal screening, going through those questions. And they are the ones who are sent to our volunteers. And we have a person that we partnered with our local Marquette University for a fellow who is overseeing that project of building that volunteer program. And we can talk a little bit later about how that's a little bit different now. And then we had the lower level needs, people who might just, maybe they just want a list of resources, they're pretty independent, but they just didn't know where to go, or they do have some questions, perhaps they just want assistance for energy assistance or something that may need a little bit more time, but may not require that time of a social worker or MSW. So, so for that level one, that green arrow, those low levels, our volunteers have some access to some resources that they can share if that is all that they want. Otherwise, all needs that are identified in those social screening are shared with our patient navigators. And so those patient navigators will walk through with them some level of, through some of their needs. If they feel that the patient's needs are higher through discussion or through how it may come out, they will then connect them to our social workers, which is a level 3 need or a high level need. So our purpose was to really, again, just kind of build on our capacity and have our staff focus in certain areas and have patients access to people who can walk them through different levels of needs. One other quick note before I let Beth go forward is that level 1 need, we have noted here volunteers, but we also work with the AmeriCorps program, and we started out with just a few, and this is our first year of building the actual program back up here at our organization. So there's been a lot of work over the last 2 years on this. So yeah, it's very exciting. So that is our aim. Our screening is done primarily through our social services department and through different staff, depending on the need of the patient. And with that, I will turn it over to the next speaker.
Hello, can you hear me?
You're good, Beth. Thank you.
Okay. I want to also extend my thanks to Albert and Eureka for inviting me to be part of this fun panel and being able to hear what other clinics are doing across the country. It's just great. My first slide just gives a little bit of information about our clinic here in Milwaukee, Wisconsin. We're a faith-based clinic serving uninsured adults in 3 community locations. All of them are in churches. Bed of Healing is a primary care medical home. Some patients are receiving care at the clinic as a bridge while they're in between providers or insurance. Others receive care at the clinic over an extended period of time. The next 2 slides just show a little bit about our process and workflow. We meet with patients at their initial visit. We ask all the standard, plus the optional, plus a few extra questions that we have added. For example, we ask, what is your country of origin? And we've learned that we have greater than 70 different countries of origins among our patient population, which really helps keep our cultural agility intact. we use the screening time to instill confidence that we have both the skill and the time to assist patients with things that are going to promote their health and well-being. Sometimes questions seem confusing, like we ask, do you file a federal income tax? When they seem confused, we quickly explain, we may need this document if we're going to apply for a patient prescription assistance program, and assure them that we don't ask any questions that don't pertain exactly to the work that benefits them. We participated in a Commonwealth Fund-supported project called the Collaborative to Advance Social Health Integration. And as part of our work with this collaborative, which was led by health leads, we developed a business case for our social needs program. And we documented that a screen takes about 30 minutes on average. It takes 5 minutes to find a pencil, paper, and a place to sit. It takes about 10 minutes to conduct the screen. And then it takes another 15 minutes to enter into the database. Of the cases that we screen, we find that we average 60% positive screens. And sometimes people think, oh my gosh, that's high, but remember, we include insurance and medical needs along with the purely social ones. We conduct universal screens, and we use a very conversational style. Staff and students are challenged to point out strengths along the way during a screen. We say 3 is good, but 4 is better. Often it feels like you're taking information during an interview, you're asking information and checking boxes. When you have frequent verbal feedback provided, it's more like you're giving to patients. And it reinforces that I'm not just searching for deficits. Instead, I can call out the strengths along the way. And that's an important part of our screening process. Initially, we expected to have a high volume of patients reporting that they had not completed high school. And after screening a number of patients, it turned out that that was a really small number. Only a small number had not graduated from high school. And then many in that small group explained they had tried GED programs, couldn't pass the math, or hated school the first time around, and they were not about to try it again. It whittled down the number of patients that were interested in getting resources. And we found that while this is valuable, it's still a very small number, and we learned that through asking that question. We do learn how many have very proudly achieved their GED, and this helps us identify our go-to resources based on their experiences. Similarly, we anticipated a high volume of yes responses to, have you been incarcerated more than 2 days in the last 12 months? Our zip code, 53205, is adjacent to 53206, which has the highest incarceration rate in the country. If you have a chance to see the documentary 53206, it's really eye-opening. But we learned that we have very few responses, which was so different than we expected. And it gives it just a shout out to using the data that you gain from asking patients and knowing how to develop your program. We use a closed loop format to document each need resolution. And our highest needs are not at all surprising. I think, can we scoot to the next slide? Okay. It's not surprising that what our high needs are. Of note, we also have a report that documents our needs we've used only once, another report needs we've used only twice, because what that allows us to document the breadth of our scope of services meeting unique needs of a patient, each patient. 2 challenges that we have found has been always a challenge in getting the reports to line up with what we need and sharing that out. And we continue to have challenges developing interdisciplinary communication with our medical team who are still on paper charts, and we use a technological platform. So being able to communicate our social needs information to the providers continues to be one of our challenges. Our initial demonstration project that was conceptualized and funded by the Milwaukee Healthcare Partnership included the task of recommending workforce configuration to address social needs. And we have had a number of feedback along the way, but at this point we have social workers. We're lucky to have a nurse care coordinator added to our team recently that's helped round out our services, and a community health worker. And we feel like having that diverse team allows us to meet a wide variety of patient needs. I just want to comment very briefly on how much the pandemic has changed everything for us, everything. But the social needs screening process that we have remains essentially the same. One thing that happened that was delightful was a group of med students had been sidelined during the pandemic. They were restricted from doing clinicals, in part because they were using up valuable PPE, and they were restricted from seeing respiratory patients and some other patients as well. And we had a group of med students, along with a group of behavioral health students, making check-in calls to our patients. They could certainly make many outreaches by phone. Their goal was to call 1,800 patients, which we're now catching up with just the last stragglers in that bunch. And we were shocked that people answered the phone. They were home, they were often scared, they had time on their hands. The students provided education, how to stay safe. They told them the clinic was open. They caught real-time medical issues. They generated mountains of social needs referrals for the Resource Center team, and we really struggled to keep up. We've given away hundreds of masks that people have made for us, and we've shared with the community. And we've developed a mini tool, which I think I listed on this screen, just a quick down and dirty question on how to just check in with patients. And these seem to be the really crux of the issue for what people were needing at this time. For the future, we've got several goals, but I just want to highlight the readiness one today. Early on, we were so enthused if anyone wanted to work on anything, and we spent a lot of time chasing them down to help them meet their need that they wanted to work on. But over time, we've gained a much better sense of timing. And for example, people often jump at the chance of getting a free eye exam and glasses. Our partner, Prevent Blindness, offers this resource to us, but patients need to provide income documentations. And we used to chase after these documents, and it was just taking an enormous amount of time. And at this point, we just pause just a bit, and when patients bring in their documents, at that point we technically open a case and fire off the application. You could have a caseload of 500 people if you were, anytime somebody said they wanted something, and then you become very unwieldy in following up. So we have done a much more cautious step, really waiting for them to make an action step. And once they've met their goal, we ask them, what are you going to work on next? We try to build on that momentum of success, and more often than not, they've got a new goal in mind, and we have built, continue to build that particular relationship. Thank you.
Thank you so much, Beth. And Rosa Maria and Maria, those were amazing presentations and a showcase of what you all are doing around SDOH screening in your local communities. And I want to take this again opportunity to say that we have been able to talk about kind of all the different implementation, partnership, and potential technology and data opportunities that you all have been leveraging in Oakland, California to Milwaukee, Wisconsin. And so just want to say that for those of you in the audience, if you have questions for the panelists, please do put them into the Q&A pod. We are getting some already. We have generated some on our own at the PRAPARE team, but we are going to honor the audience's questions first here. And so I'm going to pitch this first question to Maria here. Do you find yourself administering PRAPARE screening telephonically or remotely to your patients? And if so, how?
Hi, yes. We have actually a designated staff who, because of the COVID shelter in place, the arrangements require for her were to only do work remotely. And so this staff is responsible for conducting PRAPARE over the phone, specifically to our patients, whether they are self-pay or also those that are part of specific programs. In Contra Costa, it's the Contra Costa Cares. So we are doing those over the phone.
Great. And can I pass this on to Rosa Maria at 16th Street? Yeah, how have you all been adapting virtually or electronically?
This is a very interesting one for us. In particular, we had our volunteers previously. Our goal was to integrate this into our primary care. So our screeners were asking these questions as part of the actual doctor's visit. So the doctor would come in, do their work as well with the MA. And when there was a break in between them, when the doctor stepped out and the MA stepped out, the volunteer came in. It was like clockwork. And the volunteer came in to ask those questions, see if there was any other questions that they might have, just put a personal face to that, and then capture that information and come back. Obviously, with COVID, we have the restriction of having limited people into the office, even for anybody that we do see in the office. So we have moved to telephonic. We've tried different routes of telephonic, like when do we make that call? Do we make it before their appointment? Do we make it after? We even tried to do it on a virtual platform. So our providers are seeing our patients virtually through a platform called DoxyMe. And we tried to see if we could somehow, they could link it over to us and we could, ask the question. So trying to mimic that in-person visit. There was several challenges because our patients seem to have more challenges with technology. And so that was part of it, and getting the doctor to remember every single time. And there was just a lot of different issues. So we have actually now moved more to telephonic and are doing so with specific providers. And we get a list of what visits they have, and then after their visit, we try to contact them. We're trying to work at that perfect timing of when to contact them, because sometimes if you catch them too late, their mind just isn't on it, they're not interested, they're doing something else, so our goal was to try to somehow connect it back to the doctor's visit. So right now we're calling them right after their appointment.
Thanks, Rosa Maria. And I want to give Beth an opportunity to also chime in. What's it been like since the pandemic has started for your free clinic?
Regarding the question on reaching out by phone, we have done some screens by phone. We also have a telehealth platform. We use UpDocs, and we have the capacity to do it. But I would agree with Rosa Maria that you add value to the physician-provider visit when you have these contexts at the same time, and it has a little bit of a dissonant feel when you're separated from that. And not doing that as part of a unison team. So we can certainly do the phone interviews, but it's not as good as it could be.
Thanks, Beth. And kind of related to that, I was in conversation with Maria from La Clinica in California, and how, again, they have been trying to figure out which platforms to use, even just internally within the health center, and then to apply that externally to kind of patients and the community members. I'm curious to know, again, for Maria, which platforms have you been using? You mentioned GoToMeeting for your health education. Kind of how has that been for your staff, kind of the work experience doing that electronically and telephonically?
Yes, I think for us, a platform that we use to access the most up-to-date resources has been our local 211 database. We have been in conversations about potentially utilizing Bertha, and more recently, Kaiser announced that they are creating a platform called Thrive Local, and it's a platform that it's actually been piloted in Solano, and eventually will be expanded to the other two counties. and they will be giving FQHCs access to this platform. So it's something that we're looking forward to. I think one of the biggest challenges, we've tried developing our own database, and the biggest challenge is keeping those resources up to date, because resources might be changing constantly. So we have utilized Ann Bertha as well, more casually, like the free platform. But we've also been in conversations about possibly formalizing an MOU, and so it's certainly something that we're still considering.
Great, thanks.
But yeah.
This is a nice segue. So with my conversation with Beth and Rosa Maria from Milwaukee, Beth had talked about kind of the Milwaukee Health Partnership. And when I was talking to both of these panelists earlier this month, they mentioned, again, there is this buildup of a community health information exchange rather. So I'm curious to know from, Beth and Rosa Maria, how is that going for you all in terms of building those cross-sector partnerships and that community health information exchange? And
I'll start with the community information exchange, because I am so happy to tell you, Albert, that we just got our contract completed. We've been working to build this community information exchange with several health centers, or health systems, I should say, in Milwaukee, along with Milwaukee Healthcare Partnership and Impact 211. So Maria was talking about how difficult it is to update all that resource information. So we are looking to build a technology that would be hosted by Impact 211, and in essence, it would work as a hub, and we would that would help us gain access to this easy, streamlined referrals, including a closed loop referral. So we are in our embryonic stage, I would say. I don't even feel comfortable saying infancy, because we just built our governance group, again, primarily health systems. Our goal is to include community-based organizations so that we can make a social service system basically as navigable, is that the right word, and accessible. So it is that care coordination, but for social services. And so I'm very, very excited about that. It's been over a year and a half in its making, and that's where we're at with that. And I'll let Beth talk a little bit about one of our groups that we've been working on together, actually.
Since the beginning of our project that was initially funded by the Milwaukee Healthcare Partnership, which is a public-private consortium of health systems and public and private agencies in the area. We're very interested in how do we best solve these social need problems. And as you can see, Better Healing is a small organization, and even a big organization like 16th Street Clinic is still not able to touch all of the people in our community. And so there's always been interest in anything unified that's much broader for the community that will basically allow us to scale up. The piece that I just want to call out about the work that the partnership did from the very beginning, they convened a group that met with us monthly for several years, taking a hiatus now with the pandemic, but different groups worked on different parts of this project, and I think the learnings of one led to the learnings of the other, and a number of learning modules, pieces of information about technology and how best to solve problems has emerged. And I think that piece of collaborative work really will help our community to move ahead with this big goal of meeting social needs.
Ooh, yeah, it's no easy feat. As all three of you had mentioned, again, it really does take a multidisciplinary team. It takes multiple partners. It takes grant monies. It takes volunteers. And just acknowledging the time here, I wish we had another hour and a half or a half day to really talk through a lot of this work. But I just want to acknowledge Beth, Maria, and Rosa Maria again for their fabulous presentations. We will definitely be sharing the slides after this call. Just be on the lookout for an email from our team, the NAC side. And If you have any more questions, please do keep in touch. We do have that webinar next Thursday, the 29th, same time at 4 p.m. Eastern, and we're going to really dive deeper into this notion of cross-sector partnerships, again, in line with the theory of change that we talked about earlier, and Yuriko talked about that model from the RWJF work. So I just want to quickly wrap up and say thank you to, again, all of you for joining us here today. It's been a great second series, and so we look forward to seeing you next Thursday. So please check us out and catch you then.